Life podcast. So, before the presentation begins, I'd like to tell you a little bit about Share. So, it's a nonprofit organization that's been helping people through breast, ovarian, and uterine cancer for the last 45 years by offering support of those who've been there. And Share provides many services, including a helpline, support groups, and educational programs. All services are free of charge to participants. For more information, please visit our website at sharecancersupport.org. Also, check out our podcast, RMBC Life, which is dedicated to exploring life with metastatic breast cancer from the perspective of people living with the disease and the experts who partner with us to help make our lives better. For more information, you can visit our website at rmbclife.org, and you can find our podcast anywhere you get your podcast, any streaming device. All participants during this webinar will be muted during the presentation, and when Dr. Lake finishes presenting, we'll begin the Q&A discussion. You're welcome to submit your questions during the presentation through the Q&A section, which is at the bottom of your screen. The chat section will be disabled though. When asking questions, please remember that the presenter is unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and it will be available on the Share website and the Our MBC Life podcast very soon. So I'd like to introduce our speaker for this evening. Dr. Diana Lake is a medical oncologist with a practice that's devoted solely to the care of breast cancer patients. Dr. Lake's research interests involve all areas of breast cancer, but the focus mainly is on development of new therapies, prevention of cancer recurrence following surgery, and the treatment of recurrent disease. Working in conjunction with her colleagues on the breast cancer medicine service at Memorial Sloan Kettering Cancer Center, she is involved in clinical trials to develop better hormonal therapies and improved approaches to treatment before surgery. Dr. Lake is a past member of the National Institute of Health Scientific Review Committee and has previously served on the NIH Cooperative Group Review and its cancer education committees. She's received the Memorial Sloan Kettering Cancer Center Fellowship. She is a member of the New York State Health Research Science Board, and Dr. Lake holds a Bachelor of Arts in Biology from Hofstra University and her MD from Chicago Medical School. So please mute yourself and we'll begin. Thank you, Dr. Lake, for being here tonight.
Thank you very much for the invitation, and thank you to the audience for your interest in the area and providing any questions that you might have. So my charge today is, or the topic is metastatic breast cancer, what happens now? So I believe that the best approach is really to understand the significance of metastatic breast cancer. And I usually start by explaining to patients that this is a systemic process. So what does that mean, you may ask? Well, in order for cancer cells to travel from the breast and draining lymph nodes to other parts of the body, like the bone, liver, lungs, the cells have to go through the circulation, bloodstream, and or lymphatics. So therefore, it's systemic, and it really involves the whole person. And I'm not talking about CNS disease, which that is also included. So the next question is, how do we really treat metastatic breast cancer, and how does this differ from treating early stage disease? Well, in early stage disease, the goal of treatment is to reduce the risk of distant metastases or distant recurrence. What can we do to reduce the chance that this will show up in one of the organs far from the breast? The treatment is also for a finite period of time. In metastatic disease, it's unlikely that one would be cured, whereas in early stage, we are hoping to treat for cure. And the realistic goals of treating metastatic disease are control of disease, to prolong the time to progression, to have a survival benefit, and importantly, to maintain a quality of life. I've been doing this for years, and in the beginning, way back in the dark ages, what we were more concerned with was to treat the breast cancer or the cancer itself and kind of forgot about the patient in terms of quality of life. So now quality of life is just as important as our therapies. So patients with metastatic breast cancer usually ask, why wasn't this diagnosed earlier? And high-risk early-stage patients may say, do I need routine scans to catch this early? The short answer to all of this is no. Early detection of metastatic disease does not change survival, and there's lots of data to show that. But there's good news, and I always like to focus on the good news. The good news is that there are many options, and I hope to show you that, or at least touch on that tonight during this discussion. So how do we approach treating metastatic cancer? We really start out by noting what are the features of the tumor. What's the hormone receptor status? Is it ER positive? What is the HER2 status? Does the tumor overexpress HER2? Or is the tumor triple negative, meaning no expression of hormone receptors, estrogen and progesterone, and no overexpression of HER2? The next thing we want to do is to note what are the sites of metastases, and how do we determine that? We determine that actually through scans. PET scans. Sometimes the insurance companies will let us have a PET and a CT. What's the difference? A PET scan will clarify the activity of the sites of metastases, and a CAT scan will just show you that there's a lesion, for example, in the liver or in the bone, but you wouldn't know if it's active or not. So we also need to know if this is the first time for the metastases, or has the patient been on multiple prior regimens. And what I think is most exciting and most important is, has this tumor been genomically characterized? I mean, this is the era of genomics. So a genome, to define this, is an organism's complete set of DNA, in contrast to genetics, which refers to the study of individual genes and their roles of inheritance, such as BRCA1 and BRCA2. Genomics aims at the collective characterization and quantification of all of the organism's genes and their interrelationships and influence on the organism. So I think it's essential that genomic profiles on tumors should be studied. The purpose is to identify mutations that may be present, and we might be able to have targeted therapy against these mutations. And for example, a common mutation is PIK3 kinase in breast cancer. So treatment has changed through the years. It's become much more targeted. In years past, if you had an ER positive tumor, you had hormonal therapy, strictly hormone and nothing else. If you had HER2 positive tumor, we only had Herceptin, as that was developed in 1998, approved rather in 1998. So beyond the estrogen, progesterone, and HER2, we want to add to this mix of characterization the mutations that are identified. Is it a PIK3? Is it an AKT? And other areas that we can identify are the estrogen receptor gene, if you have a mutation of the estrogen receptor, and also something simple, androgen receptors. So they may be important. And then with all of this information, we can put together a treatment plan. So let's talk about hormone receptor positive disease to start with. The first line of treatment would be an anti-estrogen. So the anti-estrogen could be tamoxifen, although usually if a patient is on tamoxifen, we would ovarian suppress. Remember, if you have an ER positive tumor, that means you have an estrogen sensitive tumor, and it's driven by estrogen for growth. So we could therefore suppress all estrogen production. Now, if you're postmenopausal, the ovaries are no longer producing estrogen, but postmenopausal women can produce a small amount of estrogen, which is manufactured. In other words, women produce androgen, which are male hormones, and at the tissue level, the androgens are converted into estrogen through an enzyme that's called aromatase. Hence, we administer an aromatase inhibitor, something that blocks that enzyme, and you'll no longer produce estrogen. So it's shut down. Total estrogen is shut down. There are three of inhibitors. There's palbociclib, there's ribociclib, and there's abemaciclib. And interestingly, they're all about the same. They have small nuances, but when you look at trials, they really all do the job, and they're acceptable. The thing that we add, however, is nowadays are kinase inhibitors. So patients' first-line treatment, let's say you're doing fine and all of a sudden a person develops bone or liver metastases and we need to treat systemically, then we would start with an aromatase inhibitor and a kinase inhibitor, a CD4 or 6 kinase inhibitor. As standard of care therapy. And then if one progresses on this, remember treatment, which I haven't mentioned, but treatment of metastatic disease is really administering sequential treatments. So you're on something until you're no longer responding, and then we will change the therapy. So if you've been on an aromatase inhibitor with a kinase, such as let's pick Ibrance or palbociclib as the kinase inhibitor, and letrozole or any of the aromatase inhibitors, since we should have genomically profiled the tumor before we started all of this, if we find that the patient has a PIK3 mutation, then it would be quite logical to administer endocrine therapy with a PIK3 blocker, which is alpelisib, and this has been approved. So that it would be an orderly transition from one to the other. These drugs are usually well tolerated. One of the side effects of alpelisib is a high blood sugar, so we figured out ways to try to manage that. There are other targeted therapies if you do not have the PIK3 for a second-line treatment, and that is you could try endocrine therapy and an mTOR inhibitor, such as Afinitor or everolimus. So there's a growth pathway for cells. Involves PIK3, then you go to the AKT, and then mTOR. So targeting any of these pathways can definitely help, all by combining these with endocrine therapy. Likewise, second-line treatment, you could be treated with endocrine therapy alone, single agent. And then if you have a genetic mutation of a BRCA1 or BRCA2, then there's a role for the PARP inhibitors. And also, if you've genetically characterized the cells, one could consider, one could find out if you have microsatellite instability, MSI. And if you do, one might consider immunotherapy, such as pembrolizumab. So it's quite complex, and I certainly don't expect everybody to go take away the names of all of these things, but you may have heard of them, and I just want to give you an approach that we use in patients. And then third line, if you have not had a kinase inhibitor in first or second line, we oftentimes would go to abemaciclib, plus or minus endocrine therapy. So you could use abemaciclib monotherapy, or you could use whatever is left that you haven't used in the second line. We don't always have to touch base, and go in this order, but we do start out with with an aromatase inhibitor or endocrine therapy plus a kinase inhibitor. And this is all the mostly standard of care that I'm describing right now. So that's our approach with standard of care with hormone receptor positive disease. And next, I'd like to turn our attention to HER2 directed therapies. So trastuzumab or Herceptin was initially approved in 1998. Now we're 2021, and we have multiple drugs. We have pertuzumab, we have TDM1, we have Enhertu, which is deruxtecan, we have tucatinib, lapatinib, neratinib. So it's amazing through the years that we started with one drug and we have now many drugs in succession. So our current approach would be to start out with a standard therapy for HER2-positive metastatic disease, and that is a taxane, and there are several taxanes with Herceptin and with pertuzumab. And interestingly, what we can do is we tend to treat patients with the taxane, the chemotherapy, Herceptin and pertuzumab, and if one has a response, a great response or stable and have minimal disease left, you can actually stop the chemotherapy part and continue on with Herceptin and pertuzumab. So second line, if one is progressed on Herceptin and pertuzumab, you could go to something called TDM1, which is an antibody conjugate, or you could go to a new combination which has been approved, and that's tucatinib along with capecitabine and Herceptin. So the TDM1 is an antibody conjugate of a chemotherapy drug with Herceptin-like drug, and it's so-called the magic bullet to target specifically the HER2-positive cells. The advantage of tucatinib is that it may be helpful in patients who have neurologic metastases, such as leptomeningeal disease or CNS disease. In the past, we looked at lapatinib, combining lapatinib and Herceptin or lapatinib and another agent to approach the CNS metastases. Lapatinib has a lot of toxicity. I think it's plus minus whether or not it was successful in CNS disease, but tucatinib really seems to show good responses in patients who are heavily pretreated, and it's relatively well tolerated. So I throw that out. There's also, I mentioned the other drug, which is deruxtecan, and that has shown significant responses in patients with HER2 overexpressing disease who have been heavily pretreated. I think there's a 60% response rate in heavily pretreated patients, which is remarkable, actually. And then third line, you really could look at any of these combinations that you haven't had, such as lapatinib and capecitabine, or trastuzumab deruxtecan, or another one which is very interesting is neratinib and capecitabine. So neratinib is one of the, it's a small molecule, and it's just like kinase inhibitor of specifically involving the HER2 molecule, as is tucatinib. So those are some of the things, approaches with HER2 positive disease. And I think it's encouraging to note that we're looking at new combinations all the time. And the tucatinib and the capecitabine was just approved, I think, in April. So to show you that we're constantly expanding through clinical trials. So I haven't mentioned clinical trials yet, but I will momentarily. And then the last combination is triple negative breast cancer. So triple negative breast cancer does not express estrogen receptors, does not express progesterone receptors, and does not overexpress HER2. And what do we do here? This is really, I think, a biomarker-driven group. In other words, we look for things to target. So one is PD-L1, a PD-L1 receptor. So what is this PD-L1? Well, PD-L1, interestingly, helps the cancer cells to evade T cells. So it helps them to, I can use the term like to hide, and they won't be recognized with T cells, and therefore it can encourage growth of cells. So we target the PD-L1 receptor, and two drugs that do that are immunotherapy, pembrolizumab, and atezolizumab. And so those are drugs which are used along with chemotherapy, usually, to target the HER2 cell. Usually it's a PD-L1 drug would be Abraxane and atezo, or you can use chemotherapy If you're PDL1 negative, you'd use the standard chemotherapy, taxanes, platinum, capecitabine, eribulin. So these are your standard chemotherapy drugs that can be used first line in triple negative breast cancer that does not have a PDL1 mutation. The other thing that we should check for, and it's something very simple, and that is androgen receptor, because a certain percentage of patients that are triple negative, we found out that they actually may express the androgen receptor. And then for those patients, they could start with androgen blockade if they do have overexpression. And that's very nice to tolerate. And of course, if it's germline mutation, then we look to PARP inhibitors such as aliparib or talazoparib in these patients with metastatic disease. So BRCA1/2 patients are usually triple negative, but you can have ER positive tumors also. What do you do for second line treatment in the triple negative? If it's germline, you can look at to see if there's another PARP inhibitor. You can always use the standard chemotherapy, some of the drugs I mentioned momentarily, a moment ago. And you can also use Pembro as a single agent. So there's data that Pembro does have activity. And what about third line? So third line, what's exciting, the latest drug to join that group is sacituzumab. So sacituzumab happens to be an antibody drug conjugate in which the chemotherapy agent is similar to irinotecan, and that can inhibit or block a receptor called TROP2 on the cells, and therefore cause cell death, because if the chemotherapy would get into the cell, being that it's targeted with a linker, and so you have intracellular death, and then when the cells die, the material gets excreted, and you can also have extracellular death. So I think sacituzumab is exciting in triple negative. There are trials which want to look at sacituzumab in ER positive cells. There's always, again, the standard chemotherapy, which is what we've been doing. PARP inhibitors for germline tumors and Pembro can be used as a single agent in this case if they have not had it yet. So I think that the goal of what I wanted to discuss is to show you how much progress has been made in treating breast cancer. And now there are, so many options for patients. And it's very important, I think, that we fully evaluate and characterize the tumor, which is why we recommend the genomic profiling. The other thing, and this genomic profiling can be done commercially. There's a company called Foundation One that does it, and I think that there's another, might be called MyRisk. I'm not certain about that name. And at Memorial, we do impact testing, which is the same thing. There's also a company called Guardant, and so that's a quick test that you can actually have a blood sample sent, and they will assay and see if you have a PIK3 mutation. And that takes about 7 days, whereas the other tests for the genomic profiling certainly takes longer. And I think that that's important for patients. And keep in mind that all of these approaches have really been derived from data from clinical trials. So in my opinion, I have a bias for clinical trials, and I think that patients should definitely discuss with their treating physician to see whether or not there are available clinical trials. I know those of you who are being, treated at the major cancer centers in the city, this is a given. But there may be some patients who are treated by private practitioners and may or may not have access, but you should always try at least to have access to clinical trials. So clinical trials allows patients to be on newer therapy that clearly is not FDA approved yet. It allows patients the opportunity to perhaps contribute significantly to the knowledge and management of breast cancer. So I definitely would recommend that. I'm trying to see if there's anything else that I've left out or any questions that you might have. Thoughts, questions?
Yeah, thank you so much, Dr. Lake. We do have a series of questions. So we'll start from the top. A lot of your presentation actually addressed some of these questions, but I think that let's give some of them a shot, and then we'll see if more questions come up as a result. So the
Okay.
first question is, what is the best way to detect metastatic breast cancer?
So the best way to detect metastatic breast cancer is through scanning, because remember, we need to know is one responding or not. And I would say a PET scan, because a PET scan shows you where disease is, plus activity, or a CAT scan. We've tried to do both, have a CAT scan to define where the Mets are and a PET scan to look at activity, but there's a big pushback from the insurance companies.
Right.
And this also reminds me of something I forgot to mention. On the research end of things is now we are really looking at cell-free DNA. So when you have a metastatic deposit, oftentimes the DNA from the tumor is shed into the bloodstream. And so you might find, for example, that you have a patient that has metastases, they're treated with something, they have a great response, and then they recur again or relapse again. And so at that point, you still should obtain tissue and still try to see whether or not there are different genetic mutations. Because breast cancer is quite heterogeneous. So it's not that you start out with one thing and that's it for the duration of your breast cancer. And that's another advantage for being on a clinical trial where this can be done routinely.
Thank you. Can you explain the difference between recurrence and metastases?
Yeah, sometimes the terms are used interchangeably, but recurrence, if you want it to be technical, really means that one has developed breast cancer in an area that's adjacent to or near the initial primary, for example, the breast.
Mhm.
It's not uncommon for a patient to have had a lumpectomy, treated, doing fine. Years later, you come up with a breast cancer, develop a breast cancer in the same breast, and that would be a recurrence.
Mhm.
And then the question is, well, what do you do then? Is that metastatic or not? And it's a recurrence, but there's still an opportunity to cure such patients. And how do you do that? You would do the best local control, which would be surgery. And then there's data to show if you're estrogen receptor negative, that you may
Mhm.
benefit from more chemotherapy and oral chemotherapy drugs such as capecitabine. That's earlier stage. Metastases, by the traditional definition, is when you have spread of the tumor that's in a distant site from the breast.
Mhm.
So recurrence, local, metastases is distant, but sometimes people use the terms interchangeably.
Thank you. What's the difference in treatment options then between recurrence and metastases? You described some of them already, actually, so we may have already covered that question, but
Yeah. If you have metastases, then it's what we just talked about. You
yes,
characterize
exactly.
that and treat it. If you have a recurrence, and it's as the example that I just gave,
Hmm.
if it's a recurrence in the breast, then you could, and theoretically, you've already been treated, so suddenly the breast comes back, then you could treat them as you would in the adjuvant setting, as you would in early stage breast cancer.
Sure. Why is it important to know your subtype form when you have metastatic breast cancer?
Depends on what you mean by subtype. If you
Hmm.
mean lobular or ductal, that's not that important necessarily. But it is important to know the other characterizations that we talked about. In other words, the
Mm.
hormone receptor status, the HER2 status, um, androgen receptor, I'll throw into that mix also, because the treatment would be designed based on, or a treatment plan would be provided based on the characterization of the tumor, if that's what you were asking.
Yeah, no, thank you. And what are the treatment options after aromatase inhibitors or AIs or Faslodex stops working?
So after the Bless you. So after the AI, it depends on whether or not one has had a kinase inhibitor. So I would
Mm,
start that. And if indeed you've had the kinase inhibitor, you've had an AI, you've had Faslodex, you can look at other drugs, such other targets, such as endocrine therapy and mTOR inhibitor, which was Afinitor or everolimus. So we just would go down the pathway, and then clinical trials, of course.
sure. So you mentioned lobular breast cancer just a moment ago. Why is it so difficult to treat and detect?
So it depends on the growth. So normally a ductal carcinoma could grow as a solid mass, right?
Hmm.
And lobular carcinoma tends to infiltrate the tissue. So you're not going to see a mass necessarily that you can identify. Oftentimes it's more diffuse. I think that's why. So it doesn't really show up on mammography uh,
Sure.
as much as a ductal would, which is why if you suspect something, you should definitely pursue it.
And a follow-up to that would be, what sort of clues would someone have if they think they might have lobular breast cancer?
Well, I think when if you're having a mammography or you think there's an abnormality, the patient thinks there's an abnormality in her breast, um, the tissue is thickened, there's just something that's not right, then you can pursue that, and you could pursue with different imaging. You can try an MRI, um, and if all else fails, but you definitely think there's something there, then anything that's abnormal, you could always biopsy. Some
Sure.
people would wait 6 months and see if there's any change, but
Mm,
otherwise I would obtain tissue.
excellent. Can you talk about, you did talk about the genetic and genomic tumor testing. Uh, and I think we covered that, I think, already, because the benefits of genetic and genomic tumor testing for MBC patients really is in helping figure out the trajectory of the treatment options, really.
Yes, yeah. The treatment options would be based on whether or not you have mutations. For example, PIK3, you can use Alpelisib. If you have an androgen receptor in a triple negative, you could try something simple like androgen blockade.
Mhm.
Um, Go ahead.
No, I was just going to say, do you recommend for your patients that every time they have, say, a progression, an additional metastases in another location, that they get additional genetic genomic testing for those new sites?
It might not be a bad idea. I mean, I think we're looking at that, and what we're trying to do is to collect the cell-free DNA. So we're looking at other ways of
Hmm.
measuring it. I know that the genomic testing is expensive on the outside, so if you don't have access to all of this at your institution, it might be hard to do that each time. But it doesn't hurt to do a biopsy because things do change. And that's why I think we're trying to develop other panels in order to pick this up and see if there's any change, and then give targeted therapy.
Thank you. Can you talk about the life expectancy for those diagnosed with MBC at this point?
The only thing I'm just another human, so I can't say you're going to live X number of years. But if you read the textbooks or articles years ago, they would say the average lifespan of someone with metastatic breast cancer is 2 years. Now, and it's very important that people realize when you have metastatic breast cancer, this is a chronic illness like rheumatoid arthritis, like diabetes, that you probably will not be cured. The likelihood of cure is not high, but you certainly can be treated. And with each of the treatments, one of our goals is to prolong the time to progression. And you link all these together, and patients are clearly living longer. So our goal is to encourage patients to be proactive if they can, to join a clinical trial, to do everything that you can possibly do, and hopefully you will do better. You'll certainly do better now than you would have in the past because of new therapies.
Sure. And what potentially exciting clinical trials are coming down the pike now for ER positive, HER2 negative MBC patients, which is like, I think that's 80%, I think, of all patients with metastatic breast cancer,
It's a
something like
it's
that.
a large percentage. I
Yeah.
think that one we're trying to refine for example, our kinase inhibitors, we were talking about this earlier, that you might, whereas now it's a CD4/6, but you could add in CD2. So you have just trying to see what areas we can target or what molecular pathways we can target. And that's what we're doing. We're trying to put things together and see.
Yeah. Uh, Something's just, I'm just looking at our list of questions from some of our audience. Can we talk a little bit more about the metastatic breast cancer not being a curable disease and really whether it's chronic or not? And there's, I think, a little bit of controversy around calling it a chronic disease when there's no cure, right? There, you will die from metastatic breast cancer. So I'm just curious about your thoughts on that.
So it is a chronic disease because in chronic diseases, you don't cure them either. You don't cure
Sure.
diabetes, you don't cure
It's true.
rheumatoid arthritis, right? But one
Right.
is on treatment. So with metastatic disease, the point is that you do have options and we do treat sequentially. So with each
Mhm.
therapy, we're hoping to improve the response rate and we're hoping to improve the time to progression. And we do look at usually as secondary goals of clinical trials, the overall survival. So some drugs have survival benefits. And if you put all of this together, then patients are clearly living longer. And again, we pay attention to what the side effects might be. So we're trying to afford patients an opportunity to be on a trial, have a good quality of life, and oftentimes now we're incorporating uh, quality of life questionnaires uh, to the actual clinical trial to see how people are doing.
Sure. Thank you for that. So back to clinical trials a little bit. Do you have any that you want to talk about? Specific trials that you think are exciting in the ER positive, HER2 negative space?
I think I think it's there are just looking at I don't have any in particular, but I think this is something that you should go over with your treating physician. And
Sure.
that we're looking at developing new drugs. The whole thing is on new drugs.
Sure.
Um, for example, in another exciting area is in patients that have estrogen receptor mutations. So
Hmm.
you can have estrogen receptor mutations, and usually that will occur after 6 months on anti-estrogen therapy. But
Hmm.
sometimes you find patients less than 6 months. So we are looking at newer drugs now that target that.
Okay.
Um, and usually, if you have an estrogen receptor mutation, one drug that is felt to be helpful would be fulvestrant or Faslodex, but we're looking at other drugs that we can target. So I think that areas like that are exciting.
Thank you. And just staying in the line of inquiry around clinical trials, when should someone with metastatic breast cancer try to get on a clinical trial?
Day one. So
Okay.
but or maybe not day one, because I think everybody knows first line therapy, you should start with an ER positive aromatase inhibitor,
Hmm.
kinase inhibitor. And once you progress from there, so you're up to then second line therapy, I think that's the point to start on a clinical trial. And that allows you to have diagnosis of metastases. Let's get everything in order. Let's get the genomic profiling, because that takes a while
Hmm.
to get that,
Hmm.
to complete the characterization of the tumor. So I think the earlier the better, and speak to your clinician about it.
Sure. Thank you. Is there a correlation between the time of first line progression and the number of years of survival?
Yeah, I think if a patient has been, if I'm understanding, if someone's been diagnosed earlier and then now you have first line progression, and there's been years before that happened, then that's a better prognosis for these patients and to go on to the next therapy. And let's say you start them with a kinase inhibitor and an AI, they'll live for, I mean, or at least they should respond for a long time again, I would anticipate. It's the
Mhm.
patient who was just diagnosed, um, and let's say they were placed on endocrine therapy, and then within 6 months or under a year, they progress. Those
Mhm.
patients don't have as good a prognosis.
Okay. And what is the difference between the three FDA-approved CDK4/6 inhibitors? So that's Ibrance, they're known as Ibrance, Verzenio, and Kisqali.
I, no difference.
There's no difference.
I
So,
think there's
okay.
no real difference so Ibrance, which we tend to use, or I personally tend to use more, has one set of side effects. If you give the ribociclib, sometimes you have to watch the heart, so you have to evaluate with EKGs and heart evaluation. And the abemaciclib, you have diarrhea. So they have different types of side effects, but basically across the board, they're pretty similar.
And if you progress on one, say I'm on Ibrance for 20 months and then I progress, can I go to a Bemacyclib after that?
You could, but usually patients don't go directly. So I think we look although there was, I believe, out in California, there was a retrospective evaluation of like a chart review,
Mhm.
very small number, 28 patients of people who progressed on Ibrance and an aromatase inhibitor, and they found that there was a response. So usually we would, if you have progression of disease on the first kinase and an AI, you might go to something like mTOR and endocrine therapy, and then you could go back to abemaciclib.
I think that's sometimes called taking a little drug holiday from
Yeah,
one class of drugs and
right
then
to the other.
going back
Exactly.
to it. I
Mhm.
see. Okay, great. In addition to the well-known breast cancer mutations like BRCA, many other mutations have been identified in the past couple of years, as you mentioned. Are there any drugs that have been approved or in clinical trial targeting these other mutations, like CHEK2, ATM, BRIP1, or PALB2 or PALB2?
I personally am not aware of them, but I would usually turn to my genetics colleagues and ask, but I
Sure.
really am not aware. I have had in my practice a couple of patients with CHEK2 inhibition and the
Mm,
PALB1, and they're just followed very closely, but they're not on a trial at the minute. So I would have to ask.
right, right. Thank
Okay.
you. So many patients actually talk about maybe they don't feel connected to their oncologist and they feel guilty about wanting to switch with their oncologist. How should a patient address this issue with their current oncologist?
Well, I think that it's a partnership between the patient and the oncologist, number one.
Mhm.
So you should really have the oncologist explain things to you. Every once in a while, I'll get a patient and say, well, my doctor said, the best thing to do is ABC, but didn't explain why, or they don't spend much time answering questions. So I think it's really communication. So you should try to communicate with your oncologist. If that just doesn't work, or you just don't feel there's a connection, you can change. And I think that speaking to the person is a way of doing it.
Mhm.
Uh, Also, some institutions have patient reps, and you
Mhm.
can go to the patient rep and say, I wish to change.
Okay.
So I just think having a dialogue with the between the physician and the patient is the best way to do it, and then make your decision. You have to find out what's the problem.
And following up from that, when you have progression, sometimes it's a good idea to get a second opinion. But what's your policy about second opinions?
No, I encourage second opinions.
Mm,
Absolutely encourage second opinions. So and oftentimes that's when patients want to change. They
mm,
may feel, oh, that this recurred. Uh, I mean, I recurred now, so therefore I want to have a new start, new doctor, and again, it's just really going to be discussion. What
right.
are the options? And there's nothing wrong. You can tell your physician, I'm going to get a second opinion. You're being honest, and they would
Sure.
encourage it. We're all used to second opinions or patients having them. So go right ahead. And then if you find, well, I like that approach better, that's probably an easy thing to do. I'm going to get a second opinion, and oh, I like that better. Then you can tell your physician and go ahead and follow up.
Sure. And when you were talking about the importance of clinical trials, second opinions can also aid in finding the right clinical trial. So it's like a team approach, right? Looking at it,
Absolutely, it is.
look,
Yeah,
looking for a new, perhaps a new institution has the clinical trial and your institution doesn't, for example.
yes,
Yeah.
absolutely. And you can always search online now for available clinical trials.
Yes, there's lots of great tools.
Yeah.
So here's a more specific question, and it's related to Ibrance and letrozole. So, can severe pain in the upper thigh be caused by Ibrance or letrozole, or the combination of the both of them?
So I think severe pain can be caused by the aromatase inhibitors.
Hmm.
So you get joint pain, stiffness, muscle aches. So yes, you can do that.
Okay,
Ibrance, not as much. You can get more fatigue with Ibrance.
sure.
Um, my finding is I tell patients to exercise because that really helps one to tolerate the aromatase inhibitors. You're not going to have severe pain for all the years that you're on it. Um, Stretching really helps. So I think activity, if it's still intolerable, we have actually told patients you can take a break and
Mm,
nothing much is going to happen. And this works more with the adjuvant setting than a metastatic setting.
sure.
And then when they restart, sometimes we start with a different aromatase inhibitor.
Mhm. Thank you. When when should someone ask to have a genomic test on the original or primary tumor?
So, if you have metastatic disease, it's at
Sure.
that point that you should ask, and we like to do the genomic profile on the metastatic tumor as opposed to going way back and archiving tissue. So, right then and there. So I think that's part of the characterization of diagnosed with metastases. You characterize what's the ER, PR, HER2. Sometimes it may change. Um, and then you look at the androgen receptors, if that's applicable, and then you would also, all this is happening immediately, you do the genomic profile.
Yeah, that sounds right. Does medication for an autoimmune disease affect treatment efficacy for MBC?
I'm not aware that it does. It
Okay.
depends on the autoimmune disease. Um, but let's say rheumatoid arthritis is an autoimmune disease, and sometimes patients are on methotrexate.
Mm,
Um, so we would then go and speak. We try to coordinate the treatment. Sometimes treating metastatic breast cancer depends on what you're using, but that may help the autoimmune disease. Other times you can just keep going with both things.
Is an estrogen inhibitor needed after chemo and Herceptin for an HR positive, HER2 positive metastatic breast cancer disease?
Yes, you can definitely do that because a HER2
Hmm.
positive, ER positive metastatic breast cancer, there's several approaches. There is one trial that actually looked at an aromatase inhibitor and Herceptin,
Hmm.
metastatic disease. And we have used that frequently in patients who are older, uh, who are fragile. You really can't consider giving chemotherapy to them.
Mm.
So I would definitely give them if you have somebody that has multiple comorbid conditions, no matter what their age, and you may not feel comfortable with giving them, first line HER2 positive metastatic disease would be taxane H and P. If
Hmm.
you're not comfortable doing that, you can certainly use endocrine therapy and the Herceptin.
Got it. So, I'm wondering if you can discuss the viability of liquid biopsies for metastatic breast cancer patients. And you talked about that. I think the Guardant testing is considered to be a liquid biopsy. Is that
Yes.
right?
Yeah, as is to look at cell-free DNA because things would change,
Hmm.
and that's in a state of, I'm not on the molecular, I'm not involved with the molecular level, but this is what we can do certainly for patients to see what changes. So yes, and the ease of that is the patients don't have to get a needle biopsy of tissue. It's a blood sample.
Right. And if you were going to compare it, is the liquid biopsy known sometimes as the Guardant testing, is that as good as an actual biopsy and testing of the actual tissue?
So the garden testing is specifically for PIK3 inhibitors, so it's not as
Mm.
detailed as having a
Oh, I
full
see.
genomic array. That's the only difference,
Ah,
but it is good, just not as detailed.
got it, got it. And so maybe
Because
that's something that,
uh,
go ahead.
if you do a full genomic array, you'll get not only PIK3, you may get AKT, you
Okay.
might get microsatellite instability, MS1, MSI. So all of these things would be available. The Guardant, you're going to have PIK3. And that's okay because the Guardant is something that comes back in about 7 days. So if you need to know, let's say a patient's coming for a second opinion because they've been previously treated with letrozole and Palbo. So
Mhm.
now if you really need to know, you can do the liquid biopsy. If they have a PIK3, then you know exactly what you can do all in 7 days while you're waiting for the genomic full panel to come in.
So some of our listeners could even suggest that maybe it's good to have both of them done. So you get
Yes,
the
yes,
rapid result plus you get the more detailed array from the actual biopsy.
yes, you should have both done, I think.
Okay, good, good. That's great to know. So how do you decide when you're going to change treatments? Like what are the factors that you need to consider?
So the factors to change treatment would be obviously response.
Mhm.
You, and by the way, response in the setting of metastases means stabilization of disease and or shrinkage of disease.
Mm,
So stabilization is a more of a clinical benefit, meaning that it didn't get worse, but you're controlling it, if I can use that term. So that we usually change treatment. One, if the patient can't tolerate it, that's one thing to change. And
sure.
two, if there is progression of disease.
Right. Is
If
there
a patient, if a patient, so how do you know how, I thought the next question you might ask is, when do you want to scan them to see when there's progression? So, we used to say every 4 to 6 months. That really is a very fluid situation. If you have a patient that's doing well, has absolutely no symptoms, blood work is fine, they're functioning fine, I wouldn't scan them again in 4 months. I mean, you could wait a little bit.
Right, extend those scans out a little
Yes,
bit as and the blood work will tell you whether
yes.
it needs to come back up again. Sure. Is there an increased risk of ovarian cancer when you have metastatic breast cancer?
No, unless you have the BRCA mutation.
Okay, great. If someone has had a hysterectomy and is postmenopausal, also has hormone positive, ER positive cancer, is an anti-estrogen drug necessary? And if so, for how long?
Yeah, are you talking about metastatic setting or
Hmm.
early setting?
I'm pretty sure this is metastatic setting.
Yes.
Okay,
So, because remember when I said that, even though you've had a hysterectomy, your ovaries are out, so you're rendered postmenopausal by
sure.
definition.
Yeah.
But in women, it's a small percentage of estrogen, but women make androgens, which are male hormones, which in the tissue are converted to estrogen.
Hmm.
So therefore, you would still go on an anti-estrogen for that reason, and hence an aromatase inhibitor.
Sure.
Or if you don't do the aromatase inhibitor, do the Faslodex. That's still working because that small amount of estrogen has to bind onto a receptor.
Sure.
So that would degrade the receptor. And many of these clinical trials many of these clinical trials require that patients are postmenopausal. So you're postmenopausal because you've gotten Lupron, you're postmenopausal naturally, or you're postmenopausal because you've had an oophorectomy.
Yeah. So we are at the end of the questions that were submitted prior to the webinar and also during your talk. If
Mhm.
the audience that's listening has any other questions, you can post them in the chat, and we'll be able to ask Dr. Lake those questions. Um, in the meantime, while people are maybe typing in additional questions in our remaining minutes, I just wanted to mention MBC Connect is a great tool to actually find a clinical trial for yourself. And also just, it's a great tool for any metastatic breast cancer patient to check out. And so you can just go to mbcconnect.org, and it's a patient registry, and you put in your information and it helps you match to a clinical trial that might be right for you, and that you can then take to your oncologist and talk to them about it. So it's like, again, talking about having a partnership, as Dr. Lake said, is so critical. And it's really important to have that dialogue early on about clinical trials. It's super, super important. Um, And I also wanted to mention that there's a special TalkMets helpline that Share runs, and it's actually everyone who's on that helpline is a metastatic breast cancer patient trained by Share, and so you get to actually speak to a metastatic breast cancer patient who fully understands your experience and can help you find resources and so forth, and help you out in the moment. So it's a great service. Oh, and then there's another question that just did come in, and it's, will Faslodex be available orally? So right now, Faslodex is a kind of a painful shot, and I know that there's
Yeah.
some trials around this, but
Yeah.
maybe you can talk more about that.
So there are some trials around you. So Faslodex is considered a SERD, S-E-R-D, estrogen
Mhm.
receptor degradator. So there are trials now looking at oral estrogen receptor degradators.
Mhm.
And those are available only on clinical trials at the moment. So I think that should be part of this discussion with your physician. But yes.
Super. And then here's another question coming. How often should patients get a whole CT scan?
So we kind of touched about that with
Mhm.
imaging. Years ago, I mean, it's very fluid. It's not rigid. And I think patients sometimes come in and say, is it time for my scans? But the point is, if they're doing well, labs are looking well, no symptoms. Remember, you have metastatic disease. Remember, the treatment is palliative.
Mm.
So you don't have to be on top of everything every 4 months. You could stretch it out a little bit. So I think that that's just a discussion and what you and your doctor are comfortable with.
Sure, thank you. And some of the participants here are wondering if you're on social media.
I don't think so.
You're not on Med Twitter yet?
I'm not on Med Twitter. I had a Facebook page when my son was younger, only so that I could see what he was up to. Um, but
Sure.
I don't think so.
All right, all right. Well, if people want to contact you, what would you suggest?
The best way is you could call my office. I don't know any other way actually of doing that.
Sure.
So the office number is 646-888-5444. And you would just identify that you participated in the share webinar.
Sure, fantastic. Well, thank you so much, Dr. Lake, and thank you for all the great questions from the people listening. And we look forward to having you back again. But thank you very much. This has been
Okay.
terrific.
Thank you. Thank you for the invitation.
All right, take care.
Stay
Have a nice
safe,
evening.
everyone.
Yes,
Okay,
you
thank
too.
you. All right, bye-bye.
Bye bye.